For this topic, we will be discussing pharmaceutics and routes of medication administration. Now, before we give any sort of medication, and right now it doesn't matter the route, what is something that we need to do? Think of your nursing process. What's the first step? Assessment. So we need to make sure that we're doing a thorough assessment before we give any medication. So, for example, let's say we're going to give an antihypertensive. What should we be checking? If you said blood pressure, you're absolutely correct. Now, if you have an antihypertensive that also affects the heart rate, then we need to assess both the blood pressure and the heart rate. It's very important that you check this before you administer the medication, not after. You should be doing it before and after to make sure that the patient, number one, needs to take the medication. There have been many times where I've checked the blood pressure because I have an antihypertensive due and their blood pressure is on the low end. So now I need to make the judgment of holding the medication because it's not appropriate to give it to the patient. There might also be a situation where the patient's complaining of pain. So I go to get the pain medications and I do an assessment. I assess their respiratory rate, their mentation, and their blood pressure. There's been times where the blood pressure has been very low and the patient's pretty lethargic. That would not be appropriate for me to give them a medication that's going to reduce their blood pressure and cause them to be even more sedated. So now I have to do more of an investigation to figure out what's going on. And maybe I can give the patient a non-narcotic opioid analgesic that's not going to lower their blood pressure or reduce their mentation. We're going to break down the medications through the varying routes, and we're going to start with oral medications. Can you think of one of the most important things to do before we give an oral medication? If you said assess swallowing, you're absolutely correct. I need to make sure that my patient's not at risk for aspiration before I give them something that they're going to swallow. So it can be something as simple as giving them some water to sip to see how they do with swallowing. So I'll give them a cup of water and ask them to take a sip, and that's how I can assess their swallowing. If they start coughing, choking just on the water alone, then it's not appropriate to give them a pill to swallow. Now we have varying types of oral medications. The first that we're going to start with is sublingual, which you'll see the acronym SL, or buccal, which you might see as BUC. For sublingual, that literally is what it says, sub, below, lingual, tongue. So it goes below the tongue. Typically, those are oral disintegrating tablets that will dissolve once they're put beneath the tongue. Those are great for your patients that have difficulty swallowing or any concern with aspiration. The same principles apply for the buccal route, or you can also give it for an unconscious patient because that medication is going to dissolve. Other forms of oral medications include tablets and capsules. You'll see tablets on the left-hand side, and you'll see what looks like an indentation horizontally and vertically on the tablet. That is so we can adequately cut that down the middle. We can either give half the dose or quarter of the dose. So it's very important that you're reading your order to make sure how much of this dose am I supposed to give. Each individual patient should have a pill cutter, or you might have one for the unit. You just have to make sure that you clean it in between use so that you're not getting different medications mixed, and you can cut it and only get a quarter or half of the tablet. We also have capsules. Capsules can be opened and sprinkled into either a yogurt or a pudding. It's just very important you make sure to read your order. If it is an extended or sustained release, you cannot open the capsule. So please make sure you're reading your order carefully. I actually one time had a patient say, the capsules are a little big. Can you just open it and sprinkle it in some applesauce for me? And I said, unfortunately, this is extended release cardism, so I can't do that. And her response was, well, every other nurse has done it, which tells me that the patient has not been getting her medication correctly. So it's really important that you make sure you're reading that order. And I didn't throw the other nurses under the bus. I said, "Oh, I'm not sure if the order changed, but the dose that I'm giving you, it's an extended release, which means if I open this capsule, you're not going to get the medication the way that the doctor intended it. So unfortunately, I do have to keep it inside the capsule." So just make sure you're reading your orders. Another very important concept to note is if something is enteric coated. If a pill is enteric coated, that means it cannot be crushed whatsoever. When a drug is enteric coated, that means it's resistant to gastric acid fluid breaking it down. So that means it's going to go further beyond the stomach and not be broken down in the stomach. So if you were to crush that medication, you're breaking the enteric coating. One reason this is effective for any sort of patient that is going to have difficulty with gastric acid secretion, so patients with reflux, so we can give that medication so that it moves past the stomach and doesn't create any sort of flare-up. We also have sustained or controlled release. When you're looking at medications that might say XL, SR, or ER, that means that medication is not going to be broken down into the stomach and it's going to take longer to see an effect. For those medications, you cannot crush them. So it's very important that you make sure you read the medications carefully. So if it is extended or controlled or sustained release, do not crush. Next, we have our liquid medications. With our liquid medications, it's really important that we properly measure. When you get a cup to measure, you should make sure that you're on a flat surface so that you can effectively see where the meniscus is. Your meniscus is going to be located right here where this black line is. That's the curve in the surface of a molecular substance, so let's say for this case, medication, where it touches another material. That's where we want to make sure we're measuring it to get the most correct measurement. If you're giving a patient a liquid medication, and let's say it has maybe a foul odor or taste, and you want to mix it in something, please make sure that you're properly assessing the amount of volume you're mixing it in. For example, if you're going to put a small amount of medication in a large cup of fluid, now you have to make sure that the patient consumes the whole cup of fluid. And if they don't want to drink the whole thing, you don't know how much medication they're getting. So make sure that whatever you're mixing it in, it's in a smaller volume that you know the patient will finish. Next, we have transdermal. So those are patches that are going to go on the skin. On the left-hand side, you'll see what an outer packaging looks like for a fentanyl patch. Then on the right hand, you'll see that there is an initial, a time, and a date. It's imperative that you make sure that you time, date, and initial so that the nurse that's following you knows when that patch was placed, because those do need to be changed out. Every medication's a little bit different. Some patches might stay on for 12 hours, some might stay on for 24 hours, and some may stay on for a whole week. It's also really important that it's documented, because let's say the patient suddenly becomes obtunded meaning lights are on, no one's home, respiratory rate is low, and you're not sure why. If you didn't know that the fentanyl patch was on, that could be the reason that it's occurring. So if you had no idea, you wouldn't know to look for it. So that's why it's really important that we properly document and assess that a patient has a transdermal patch on. It's also very important that as the provider putting it on, that you make sure you're wearing gloves. That medication can be transferred into your system and cause an effect in you. So can you imagine if you were putting a fentanyl patch on your patient and you weren't wearing gloves, and now suddenly you're lethargic, you're sedated, because now the fentanyl is in your system. So always make sure to wear gloves. One reason that transdermal patches are so great is it provides a consistent amount of drug over a specified time frame. This reduces the risk of overdosing, especially in patients with chronic pain. It's also very important that you are aware transdermal patches are not for an acute, short-term management of pain. This is for your patients with chronic pain issues. Some examples would be patients with cancer, chronic back pain, or any other chronic pain-related issues. This would not be for somebody who broke their leg or had a surgery and they're acutely recovering. Only assimilate this with something chronic. Next, we have topical. Topical is anything that's going to be absorbed through the skin or any body surface. So that drug is going to be delivered over a longer period of time. It can have a slower onset, but your duration of action is going to be much longer. It's really important that you're mindful of the amount that you're also applying, because it's not something that you can easily just remove or take off once it's absorbed into the skin. It's also very important that you utilize proper technique. When you're taking a medication out of the container, don't reapply a tongue blade or a cotton tip applicator that's already touched the skin. Once that's touched the skin, if you need more of the medication, you should get a brand new applicator to make sure that you're not getting whatever's on the skin into your vial of medication. It's also very important that you wear gloves if you're applying it. Same principles as discussed with the transdermal patches. We've in the past had a student who was applying a nitroglycerin patch and topical agent, which is a very potent vasodilator to patients that are having chest pain. And they were not wearing gloves, and they ended up passing out because it also causes you to become very hypotensive. So just remember, you always want to wear gloves no matter the situation. As you can see in this picture, what you see wrong, they're not wearing gloves. Very important. Please always wear your gloves when you're applying a medication. We also have our eye installations. We can either have eye drops or eye ointments. For applying eye drops, you'll want to have the patient tilt their head back and make sure they're looking up. With one hand, you're going to pull the lower eyelid down and away from your eyeball to make a little pocket for the drop. Then you're going to squeeze your bottle, and you want to make sure that you don't touch the eyeball because you don't want cross-contamination. And you're going to squeeze how many ever drops are prescribed. Then you want to instruct the patient to close their eyes, and you want to press your finger lightly on the lacrimal gland, which is your tear duct, that small hole in the inner corner of your eye, to prevent that from draining into your nose. If you have a patient that requires multiple eye drops, you would want to wait at least 5 minutes in between each drop. With eye ointments, you're going to utilize the same principles. However, instead of it being a drop, you're going to apply a thin line of that ointment along that lower eyelid. You can then ask the patient to blink a few times to allow that ointment to be dispersed throughout the eye. For eardrops, I'm going to give you a simple tool that should help remember how do I administer them. When you're administering to an adult, you want to pull the ear back and up. If it's for a child, you're going to pull the ear back and down. When administering a nasal spray, you should lean forward slightly and press on that nostril you're not treating. Then you're going to inhale gently through the other nostril as you either push down on the nozzle or compress the bottle. It's also important to make sure that you're cleaning the tip of the applicator after every use, just to make sure that you're reducing the risk of spreading any microorganism. When you're using a metered dose inhaler, it's important that you make sure that you're taking a nice deep breath out first. Then you'll want to take a nice deep breath in, compress the inhaler, and then hold your breath as best you can for a minimum of 10 seconds, and then slowly breathe out. One thing that's actually very beneficial when utilizing a metered dose inhaler is a spacer. When using a spacer, this ensures more delivery of the medication to the patient. The spacer is going to be a chamber, as you can see on the picture on the right, that you attach to the metered dose inhaler. You'll squirt the medication into the chamber, which allows the medication to sit in the chamber and more time for you to breathe that medication in. Reason this is more effective is a lot of times when patients are using metered dose inhalers, they're actually delivering the medication to the roof of their mouth and they're not actually inhaling it. So it just provides more effective medication delivered to the lungs. It is really important that when you're doing teaching, whether for an MDI, metered dose inhaler, or just using a spacer alone, that you do a return demonstration. Have the patient show you how to administer it to themselves so that you know that they know how to effectively utilize it. A lot of times I've seen nurses give instruction and they don't do a return demonstration, and you don't have an idea if the patient truly understands or were they just saying yes because they weren't sure what you were saying. So always make sure you get a return demonstration to make sure that you know your patient understands your teaching methods. Another route is through a nasogastric or a gastrostomy tube. NG meaning nasogastric, so you'll hear that referred to as an NG tube, and the gastrostomy tube as a G tube. You can also have a J tube, which is a jejunostomy, or also a GJ, which is a combination of a gastric tube and a jejunostomy. When given medication through these routes, it's imperative that the medication is crushed thoroughly so that it can go down the tube and not clog it. If your patient has an NG tube, it's very important that you understand why the patient has the NG tube in the first place. There's a couple different reasons a patient might have one. First is possibly do they have swallowing problems? Since they can't swallow and they're NPO, we've put in a tube to allow either medications or food delivery. So feeding through feeding tubes. Or the other reason could be that the patient has a bowel obstruction. If the patient has a bowel obstruction, they're going to have the NG tube in for decompression. So basically, we're sucking out contents from their stomach. If your patient has an NG tube in for decompression because they have a bowel obstruction and they're nauseous, we need to verify that it's actually okay to give a medication through that NG tube. Sometimes we will give medications through NG tubes even if it is for decompression, and we have to make sure that we do not hook it back up to suction for a minimum of 30 minutes to allow the medication to absorb. There might also be an instance where the physician says absolutely no medications because the patient's not able to absorb them. So it's really important that you ask that question. We do also have suppositories. You can give a rectal or a vaginal suppository. Some reasons you might give a suppository, mostly rectal, Tylenol. We give Tylenol very commonly. Those are for our patients that come in, they've had a massive stroke and they're not able to swallow, and we cannot give Tylenol down the NG tube for whatever reason, so we do a rectal suppository. Majority of the vaginal suppositories you'll be giving are your antifungals for things like a yeast infection. For the route of parenteral medications, this is anything that's going to be administered through an injection. That includes intravenous, intramuscular, subcutaneous, and intradermal. It is our fastest route of drug absorption over enteral and topical. Out of all of the parenteral routes, intravenous is going to be your fastest. And just as a gentle reminder, parenteral is going to bypass your first pass effect. On the left, that is a photo of me giving my very first injection in nursing school ever. This is an example of an intradermal injection. Intradermal meaning it goes below the epidermis, but it's above the subcutaneous and dermis. We use what we call a 1 ml tuberculin syringe, and this is most commonly utilized for doing our TB testing. Next, we have subcutaneous, which means it's going into our fat tissue. So it's below the dermis and the epidermis, but above the muscle. We give this through a 45 to 90 degree injection, so making sure that that syringe is rotated, and we give it into any of our subcutaneous areas of our body, including we can give it on the abdomen, our thighs, the lateral aspect of our arms, and the fat pad below our scapula. Next, we have intramuscular, and we do have multiple sites that we can administer medications through. It all depends on the type of medication you're giving, if it's highly viscous, the volume of medication you're giving, and the size of your patient. So we can give an intramuscular injection through the ventrogluteal site, deltoid, vastus lateralis, and then we also have a method called Z-Track where we're retracting the skin, and that's to make sure that if it's a very highly viscous and thick medication, that it stays within the tissue and doesn't leak out. Most commonly, your intramuscular medications are going to be your flu shot. We do also have antibiotics that we can give intramuscularly, as well as some narcotics and sedatives. Next, we have intravenous. Intravenous is going to be a systemic effect. It is the most rapid form of medication administration that we have. We do utilize peripheral venous access. We can give medications either through an IV push, a continuous IV infusion, or an intermittent infusion, which we also call an IV piggyback. This is a picture here of me starting my first ever IV in nursing school. Just as a gentle reminder, you are going to have a rapid onset. That is important to note. So that means when you're giving a medication, you should expect to see effects relatively quickly.